In this video, you're going to learn how to recognize solid and cystic pancreatic lesions on EUS, one of the most crucial skills in pancreatic imaging. We'll go case by case, each image telling you a story, and each pattern helping you master the art of interpretation. So let's begin. Here's the first image, a classic pancreatic adenocarcinoma. Notice the focal hypoechoic, inhomogeneous mass with poorly defined, irregular margins. Some fibrotic strands are seen within. And those dark, anechoic areas, that's necrosis. This is what makes adenocarcinoma look so sinister, irregular, infiltrative, and destructive. Remember, the more ill-defined and heterogeneous the mass, the more suspicious it is for malignancy. Now look at this, a discrete, well-circumscribed, hypoechoic mass in the pancreatic body on linear EUS. Unlike adenocarcinoma, this one looks round, smooth, and sharply demarcated. It's the personality of a neuroendocrine tumor. Neat, compact, and often hypervascular on Doppler. It almost looks polite until it isn't. Here's a large, messy lesion, heterogeneous, with hypoechoic necrotic areas. This is solid papillary epithelial neoplasm. And here's a tip you must remember. When performing EUS-guided FNA, target the hyperechoic viable parts, not the necrotic zones. That's where you'll get better tissue yield and diagnostic accuracy. This is how you turn image interpretation into precision sampling. This one's interesting. A round, homogeneous, well-defined hypoechoic lesion. This is pancreatic metastatic lesion. Unlike primary tumors, metastases usually look neat and symmetrical, often multiple and well-circumscribed. If you see a too perfect pancreatic mass, always think of metastasis. It could be from kidney, lung, or even melanoma. Now look at this striking image, a large, well-circumscribed mass in the pancreatic head with multiple tiny cystic spaces. This is the classical honeycomb pattern of Serous Cystadenoma. It's benign. Notice one larger cyst. That's your target for EUS-FNA if you need confirmation. This one tells a different story. A large cystic lesion with internal septations in the pancreatic body. When we aspirated the cyst fluid, it was thick and mucinous, confirming a mucinous cystic neoplasm. Think of it as the quiet one with malignant potential, usually seen in middle-aged women. Here's something you must never miss. A cystic dilatation of the main pancreatic duct with a solid mural nodule. The aspirate showed high mucin content and atypical mitotic cells, confirming main duct IPMN. Remember, main duct involvement equals high risk. These need surgical evaluation. Finally, here's the transformation. A large cystic mass with solid components. The cyst fluid had high CEA levels, and the FNA revealed malignant cells. A mucinous cystadenocarcinoma. This is how a benign mucinous cystic tumor crosses the line into malignancy. Each of these lesions, from adenocarcinoma to cystadenoma, has its own signature on EUS. The key is pattern recognition, hypoechoic versus hyperechoic, smooth versus irregular, cystic versus solid. And once you can read those signatures, the pancreas starts speaking to you in echoes. If you found this video helpful, make sure to subscribe for more EUS learning sessions, concise, visual, and clinically relevant. Till next time, keep observing, keep questioning, and keep imaging with precision.